now it's my pleasure to invite Dr. Manchaiah for his talk. So Dr. Vinaya serves as a Joe Mayo Endowed Professor of Speech and Hearing Sciences at the Department of Speech and Hearing Sciences, Lamar Universities, Texas, United States. He also has a position as adjunct faculty at the School of Allied Health Sciences, Manipal Academy of Higher Education, India. He has worked in various clinical, research, teaching, and administrative roles, and his current academic appointment predominantly works on research and research leadership. His research focuses mainly on improving the accessibility, affordability, and outcomes of hearing and balance disorders by promoting self-management and using digital technologies. Dr. has published over 140 peer-reviewed research papers and 5 books. So he is one of the experts who worked extensively on ICF and tinnitus and hyperacusis. He is the expert in this area. So I invite Dr. Vinay to give his lecture.
Okay, hello everybody. Just wanted to sound check. Can you all hear me okay?
You can hear you.
Okay, excellent. Well, thank you all so much for joining this talk. My talk today is on applications of International Classification of Functioning, Disability and Health, in short ICF, in tinnitus and hyperacusis. I just want to make a disclaimer that I have no experience working with hyperacusis patients. Our research mainly focuses on tinnitus, but I think the model can be applied in both populations. So hopefully you'll make inferences on these things. I work at Lamar University, which is based in the southeast of Texas, but I live in Houston, which is about 2-hour drive from Lamar. We have a doctorate program for audiology, and we also have a master's program for speech pathology. While I when I live here in Houston, we have something interesting to share. That is that I'm only about a mile away from the largest medical center in the world. So if you think about the US, you probably have heard about Las Vegas, which has these huge casinos. So we have something like that in Houston, but for medicine. So I have this picture here in the right hand side. So I just thought I'll mention this to you because if you happen to come to this part of the world, please do get in touch and I'll be happy to give you a quick tour of this. Okay, so the plan for today, in the next 40 minutes or so, I plan to very briefly talk about heterogeneity associated with tinnitus and hyperacusis. But my main talk today would be to focus on ICF. But before we talk about ICF, I'll have a very brief introduction to different models of disability, and then talk in a lot more details about the ICF framework as well as classification. And then finally, I want to maybe end this talk with a little bit of a clinical scenario, maybe a case study on how this model or classification can be helpful for this population. Okay. And I also wanted to mention that this talk is introductory. That means you don't need any prior knowledge of this model. Written it in such a way that anybody without any background in this model should be able to understand something from this talk. Okay, so this is no new information that tinnitus is quite a common condition, affecting anywhere between 10 to 15% of the general population. But the interesting thing here is that although it does affect being experienced by a large population, only a few people with this condition are really bothered by this condition. The rest have tinnitus, but they're really not bothered or affected by this condition. So this is quite strange compared to other health conditions that we know. Because in other health conditions, most of the time, a large percentage of the population are bothered or affected by the condition. And it seems like there is a lot of variability or heterogeneity. And this can be grouped into 4 elements. And the first, there is a lot of variability in terms of how the tinnitus is perceived, different types of sounds, different duration, and so on. And then what causes tinnitus can also be very different. So the risk factors and what actually may have resulted in tinnitus varies from patients quite differently. But most importantly, the last two elements, which is a distress associated with tinnitus. So people may hear exactly the same sound or the same level of sound, same type of sound, but their distress, that means how badly they are affected, may vary quite a bit. And for us as clinicians, it is also interesting to note that the treatment responses, like how these people respond to different types of treatment, psychological interventions, sound therapy interventions also seem to vary quite a lot. So now let's take a pause from tinnitus, and then let's think about disabilities, how disability is defined, and what are the elements of disability, and so on. So if you take a broader definition of disability, then it is usually, it usually covers elements such as impairment, activity limitations, and participation restrictions. So generally, impairment is a problem that affects the body, body structure or body function. Whereas, as a result of impairment, people may have some activity limitations and participation restriction. So when we say activity limitation, this is something that refers to for people not being able to perform an activity, like for example, not being able to hear and not being able to listen. On the other hand, the participation restriction refers to because somebody cannot do a particular activity, they cannot participate in a meeting. For example, if you are not able to hear, then you may have difficulty participating in a meeting, or in a social activity, and so on. So, in a broader term, disability refers to all of this together, not just what goes on in the body, but it is also how people, how this problem in the body structure or function manifested in their day-to-day life, and it also includes how a person copes with this condition and how the society either makes this disability worse or better for that individual. When we look at disability, there are different models that try to explain disability. So the two common models are a medical model and a social model. In a medical model, the idea is that the problem is usually in the body. So that means the medical model focuses on impairment. And because of this way of thinking, the idea behind treatment is that if you treat an impairment, then you should not have a disability, or the disability should go away or disappear. Whereas in the other model, which is completely opposite way of thinking to medical model, is the social model. And within the social model, the idea is that, well, disability is not within the body, but instead it is in the society. Okay, so there are barriers for people facing conditions. There are different types of environmental and social barriers, and that is what defines disability, and that is what determines what kind of consequences people may have. Different people may have. Both of these models seem to have some important elements for us to understand disability, but again, both of these models seem to miss an important point, in the sense that in medical model, they only look at what is within the body, but they may not recognize what is outside, whereas in the social model, they only look at outside and may not recognize what is within the body. So in the last few decades, the idea of biopsychosocial model has become very popular, and that is the foundation, that is the basis for this ICF model or classification. In addition to this, there are many other models that try to provide an explanation for disability, which includes cultural model and many other, which I won't be talking today. So now, in the context of tinnitus, we know that this problem is within the body, in the sense it is manifested within the body. But let's also think how an environment or a personal factor could affect or influence tinnitus. Here are a few things that I took from our fairly recent studies. So here is a recent survey that we did across the globe, where we asked individuals with tinnitus what kind of changes they noticed during the COVID-19 pandemic, especially during the initial lockdown phases. And we noticed that just over 30% of the respondents suggested that they have, whatever that has happened around them due to the pandemic and the lockdown has increased their tinnitus distress. Okay, so which is basically kind of suggesting to us that environment may have some bearing towards the perception of tinnitus. And then we also have done some studies where we were able to very interestingly record what is called as positive experiences associated with tinnitus. And again, in open-ended questions, we were able to see just over 30% of the people reporting some kind of positive experiences. And when I say positive experiences, this is not like where individuals with tinnitus celebrating saying, "Oh, I'm so glad I have tinnitus." It's not that way. It is more like, well, I have tinnitus, so because of this, I became more aware of other disabilities, and I'm more, empathetic to other people with disabilities. Because I started noticing tinnitus, I take care of my hearing more, and I focus on personal development. My outlook to life has changed, and so on. So this way of positive psychology seemed to tell something about the individuals. It kind of tells about their coping behavior, and more so about the temperament. How they would deal with a particular situation. And there's only a little research on this. So I don't want to talk too much on this, but instead just mention that the distress associated with tinnitus can be mediated by environmental and personal factors. Okay. So now moving on to the World Health Organization ICF classification. As talked earlier, this is an integrative model that focuses on biology, psychology, and social elements. So that's why it's a biopsychosocial model of functioning and disability. So the key aspect of this is that it kind of looks into interaction, a complex relation between health condition and contextual factors. Okay, so I'll come back to that point on health condition and contextual factor and talk in more detail. But this is not a new model. This was World Health Organization kind of announced this model in 2001. So there is about 20 years of history to this. But even before the ICF came out, biopsychosocial model has been there for quite some time. So it's not a new model by any means. And also, it's been quite well adapted within audiology. Like if you look at many clinical practice guidelines for rehab, they seem to embrace this model, and they seem to think that it has more value compared to solely the medical model or a social model. Okay, so this illustration is a bit complex, but the idea here is that you have health condition, and health condition can be mediated by a number of different things. So you have functioning and disability, which includes body function, body structure, activities, and participation. And you also have what is called as contextual factors. And the contextual factors include environmental factors and personal factors. So the idea here is that a health condition, the experience of a health condition, a health status, or a health problem somebody may have, is really mediated by all of these factors, like what kinds of body structure, function they have, and as a result, what kinds of activities and participation limitations they may notice. And also, more importantly, how environmental and personal factors may mediate these kinds of effects. This illustration is used quite a lot, but I do find this quite difficult to read and understand. So we rewrote this image. We rewrote this basically to have a better or an easier illustration of what this model is all about. So if you see here, you have in the one corner disease, a health condition or a health problem somebody may have. But usually what is important for us when we think about a health condition is that how badly a health condition affects our quality of life or a wellness, or in other words, how limited this may have if you have an intervention, reduce the effect of a disease or a health condition on a quality of life. So we have in one end disease, and you have other end quality of life or a wellness. So we have many other factors in between. For example, if somebody has a health condition, then it is likely that they may have some kind of impairment in their body. They may have something wrong in their body structure, and that may result in something wrong in their function. And because of this problem, they may have some kind of activity limitations, like in hearing. There may be something wrong in their external ear, middle ear, or inner ear, or maybe in the auditory pathway. So that may result in activity limitation. That means not being able to hear, not being able to listen, maybe in certain settings and so on. And then that may result in participation restriction, which is basically, I cannot attend meeting, I cannot go to school, things like that. But what is interesting to note is that the effect of this is usually mediated by other things. For example, when we look at impairment, it is to what degree, what type of impairment, and to what degree there is an impairment, and then more importantly, the contextual factors like environmental factors and personal factors may have bearing towards the effect this disease may have on quality of life. Sometimes we may have a health condition, but they do not have any effect on quality of life. The individual may be living a perfectly healthy life. Whereas in other time you may have a disease, and more commonly you may have a disease where that is really affecting the quality of life quite badly. Okay, so the nice thing in this model is that the ICF recognizes that environmental factors can be either facilitators or barriers. So environmental factors can either make the condition better or worse in the way it is manifested. And there are also some grading system on to what degree it can work as a barrier or a facilitator. But for unfortunately, not many people use this classification. We just tend to kind of think about do they have any effect, but we don't usually classify as mild, moderate, or severe effect. But it can be very useful if somebody does develop some questionnaires where they want to study to what degree these factors can be better. If just to illustrate this, let me take a few examples. For example, with tinnitus population, we know from lots and lots of history that most people tend to find their tinnitus bad when they're in quiet situations. But during our management, clinical management, what we tend to do is to make small changes to the environment. That means introduce a light background music, and just that small changes to the environment is likely to make their tinnitus perception different. In the sense, a lot of people seem to have a much better coping strategy when they are in a light background music. So this really illustrates that environment has a big influence on how the tinnitus is perceived. And while the ICF suggests this kind of idea only for environmental factors, I also think that this same thinking can also be applied for personal factors. ICF does not give a lot of details on the personal factors. There are some classifications that are suitable for audiology on this. And again, think about how people cope. Some people, when they have experience of tinnitus, have a passive coping strategy. Oh, I just switch off. I cannot do anything. I just stay home. Try not to do anything. So, which is kind of a negative or a passive coping strategy. Whereas other people with tinnitus may tend to act more active, saying, if I have this tinnitus, I tend to do this. I tend to exercise. I tend to maybe try to do something that distracts me from tinnitus, and so on. So, a slightly more active or a positive coping behavior. So what I'm trying to illustrate here is that within the ICF classification, we think about this environmental and personal factors a lot more depth, or we give a lot of prominence to these factors compared to other disability models. Okay. So another really important element of this model is that this model recognizes that somebody could have a problem in the body, but they may not experience disability. They may not experience, difficulties. So somebody may have a perfectly good, may have a problem in the body, but it's not manifested. And on the other condition, somebody may not have any problem in the body, but they may still have some kind of issues they're experiencing. So here I'm taking a couple of examples. Again, some extreme examples to kind of illustrate this point. So here you can see an audiogram with normal hearing thresholds, and in this, let's say that we take a lot of history, and the person is really complaining a lot about not being able to understand conversations. And let's say you did not have the ability to diagnose, like to look closely in terms of what's going on. You just have an audiogram, but somehow that audiogram result does not translate to the complaints that people are making. So that means we haven't found what the problem is in the body, but clearly there is manifestation of that problem. That means people are reporting severe problem in understanding speech and communication. So the question there is, should we do anything with them, even though we are not finding a problem? Then the answer, according to the ICF, is yes. We should try to find some solutions for this problem for this person, although we may not get to the bottom of what the condition is. I kind of added this ANSD and APD as an example, but in those, we know that there is underlying problem in the body. That means you do have some impairment in the body if you look close enough. But if you do some superficial examination, then you don't usually find that. So the point I'm trying to make here is that sometimes we could have no measurable or no identifiable impairment or no measurable problem, but people may still complain that they have hearing disabilities or hearing problems or communication problems and so on. On the other hand, you also may have sometimes identified problem in the body, but there is no hearing disability noticed. So here are some examples of psychophysical tuning curves. And if you see the bottom right hand corner, you'll see some of these black curves, which are basically pointing to one frequency. So in a good inner hair cell functioning, this is what we should see. We should see that this the curves are like pointing to one frequency. Whereas if you see some of these results on the top, you see that they're actually not as seen in this black. Instead, they're kind of indicating some kind of abnormality in the inner ear. But if you look at these particular cases, audiologic results, so they seem to have good hearing in terms of audiogram. The autoacoustic emissions are present. If you do a fine structure autoacoustic emission, you do see some dips, which kind of associate with this thing, but they don't have any problems in understanding speech. No reported history or complaints. And if you do a speech testing, they seem to have a good performance in speech testing. So here, the idea is that while there is an impairment that we find, clearly the test results are showing that there is something wrong in the body. The person is not experiencing any speech problem, speech understanding problem. So again, ICF has an explanation for this, saying that while there is a problem in the body, they may not experience issues because maybe the contextual factors, maybe the environmental factors, or the personal factors may be mediating these issues. That's why they're not noticing. It doesn't mean this person never need rehabilitation. It's only at that point in time. Maybe in future, if the hearing get worse, or if the other personal and environmental factors change, then this person may do notice hearing problems and may come to seek rehabilitation. But I think the point I'm trying to illustrate here is that within this model of ICF, it does recognize the fact that somebody could have an impairment but not have any disability or problems. Whereas in the other hand, somebody could have a disability but not have any impairment. So these are two extreme conditions, but it can happen. So within ICF, we can think about ICF in two ways. One way of thinking about this is to look at ICF as more like a framework or a model. That means when I'm thinking about a rehabilitation, when I'm thinking about an assessment, I would take an approach of biopsychosocial. That means I would look at biology, I would look at psychology, and also in the individual aspects. Whereas if you think about this as a classification, then the idea behind classification is to code different elements of body function, body structure, activities and participation, also the contextual factors, into specific elements of ICF coding structure. So if you look at the ICF classification, then it has 5 parts as illustrated here, and within these parts you also have subsections. Like usually if you have an element, you may start with which of this part it belongs to, and then you try to code them to as finer code as possible. Generally, it can go up to the 4th level. The bottom codes are very specific to a condition or a problem, whereas something on the top are much broader. But for most people, this classification may not be necessary. That means you don't need to learn how to code them and so on. I think a way of using framework or a model is perfectly sufficient. So I'll hopefully illustrate that point later in this talk. But when initially the ICF was developed, the idea here was to come up with a mechanism or come up with a systematic coding scheme which can help gather information about healthcare and then try to, so that you can compare different conditions, you can compare different healthcare systems, you can compare different country health information and so on. So they designed it in such a way that you could actually map both your clinical investigations as well as your self-reported questionnaire data into this framework. So you could actually map your hearing test results, any kind of scans and things like that that were performed. In addition to that, you can also map any self-reported, patient-reported outcome measures and open-ended question data into this ICF classification. Okay. While in the beginning the idea of this model was to develop something that is used for comparing health health conditions or health systems, the role of ICF has evolved over the years, and I think nowadays ICF is seem to have these 3 main goals. And the first goal is to provide a common language for understanding and describing health as well as health status. The second is that this model or framework helps identify or highlight the relationship between health and also activities in the daily life. How health can manifest different things in terms of activities in terms of daily life. And then the third point is that here the emphasis is placed on the functioning. Okay, so it places functioning and disability in the context. So functioning is how well somebody is performing, whereas disability is how badly somebody may be performing in a condition. So within the ICF classification, there are approximately 1,400 codes. So if you go to the 4th level coding of this, then you would see that if you look at these 5 different chapters, well, the ICF does not give any information about personal factors, but coding for personal factors, but it does have for other 4 chapters. So there are about 1,400 elements. So the reason you have so many elements is because the ICF was developed to be more culture neutral, and also so that it can be applicable to any health condition from anybody anywhere in the world. So they wanted to be as comprehensive as possible. So they kind of put together a book that covers almost everything. Okay? So I say almost everything because there are still elements missing. When we do field studies, we still find things that are reported by people which are not covered in this book. So if they do release a new version of this, so it was released in 2001. So let's say in the next few years, if they do release a new version of this, there's plenty of research highlighting that something is missing and that should be added to this classification. But even with this 1,400 codes, it is still too much to handle. That means for a typical clinician, we cannot remember or handle these many codes. So what an organization recommends is that when we apply this ICF model or a classification, maybe we should do studies and develop what is called as a core set. So the ICF core set. So the core set here basically means that we look at a particular health condition, apply ICF, and then determine which of these 1,400 codes are most important when we study a particular health condition. Like if you study hearing loss, which elements we should be more concerned about. If you study tinnitus, which elements we should be more concerned about. And there is a clear and a well-defined system on how to develop this. It is very time-consuming and also very expensive. to do this kind of project, and it usually goes in 3 phases. So the first phase is where researchers, usually they put together an international research team, and they gather a lot of data through systematic reviews, focus groups, expert surveys, and also doing cross-sectional studies in multiple centers across the globe. And in the second phase, these data is condensed, and then they'll put together an expert panel. And again, that should be a global panel that includes people from across the globe, who decides based on these field studies that were conducted in phase 1, what kind of which of these elements should be included in the core set. And then in phase 3, we have this core set being validated. That means you kind of create some instrument using this core set and study which of these elements are more useful and less useful, and so on. So I was very fortunate to be part of the ICF core set creation. So here is a conference that was held in Denmark, in Artican Research Center in Denmark in 2012. So this project was aimed at creating ICF core set for hearing loss. So they did a lot of these preparatory studies discussed earlier, gathering data from systematic reviews, focus groups, and field studies using questionnaires, and then brought all of that together to ask experts, which of these should be included in the core set for hearing loss. And the task for the expert group is to create categories, like as few categories as possible in the brief, and as many as necessary in the comprehensive core set. So the idea here is that we create, out of these 1,400 items, we create a small set of items that are most important when we study a particular health condition. So following that conference, an ICF brief core set for hearing loss, which included 27 items, and ICF comprehensive version for hearing loss, which included 117 items, were created. Now the researchers in Sweden who started this project are also validating this project, and I'm also involved in gathering some data for these studies. But unfortunately, there are no core set developed for tinnitus, so there are very few studies that have examined tinnitus using this framework. So here is one of the earliest study from India. So it's quite a nice study where researchers took a commonly used questionnaire, tinnitus handicap inventory. They mapped the items into what elements this questionnaire is testing, and I think they did add a few additional items here. But generally speaking, most of the items were testing body function, and a few items testing activity limitation, participation restriction. And they tested this on a small population. I cannot remember how many, but I think it was in around 20 people, I think. And what they found was that within the tinnitus, body function was significantly more affected than activity limitation and participation restriction. That means tinnitus has affected the body, but it doesn't really affect how somebody was living their daily life. But while this was an early study, and I think a nice study, it had a lot of limitations. The questionnaire that were developed did not have a good number of other elements like participation restriction. It did not gather information on environmental factors and personal factors which may mediate how the tinnitus is experienced. So in a fairly recent study, we applied ICF classification and also on tinnitus population. But in this study, the data was gathered using open-ended questions. You're asking people to come up with what kinds of problems they may have experienced and how their life may have changed as a result of tinnitus. And we coded these open-ended responses into an ICF classification. And this figure illustrates saying that while we have people reporting elements of body function, activity limitation, and participation restriction, and also some contextual factors, the results of this also strengthen the previous study results, saying that tinnitus is generally a body function issue, but some people with tinnitus also may notice some activity limitation and participation restriction. And the interesting thing also here is that the environment and personal factors can mediate the experience of tinnitus. So that's an interesting finding. This study was only done in people who were seeking psychological intervention, people who enrolled in our trials. But my hypothesis is that those who may be bothered by tinnitus, those who are really suffering by tinnitus, for them maybe there is more activity limitation and participation restriction. Whereas those who have a tinnitus but they're not really bothered, maybe for them it is more of a body function issue. And again, this is just my hypothesis. I think it will be nice to do some studies looking at how different subgroups of tinnitus populations may have different elements, when we apply the ICF classification, and maybe that is for future. So far, it was quite theoretical, and I was only talking about how this model is applied, and mainly in the perspective of research. So now let's take a clinical route. Let's see how this model can be applied in the clinic. When we think about rehabilitation or a rehabilitation cycle, then generally speaking, we can have these 5 steps, that kind of goes from planning the rehabilitation, implementing the rehabilitation, as well as assessing the effects of rehabilitation. And the first step usually starts with identifying the key problems as well as key needs. What kinds of problems somebody is noticing, and what they want to change in their life. So that is the first step. And the second step within the rehabilitation cycle is to understand, are there any modifiable or limiting factors? So this person has this condition. Does it get better if they do something, or does it get worse if they do something, or if they're in a particular situation? So there is a second point. Thinking in ICF terms, it is looking into the contextual factors, environmental and personal factors. And then the third step within the rehabilitation cycle is to define the target problems, target mediators, and select appropriate measures. And then the fourth step is to implement them, and the fifth step is to assess the effects. And again, I think what you note here is that we are not just studying the problem, but we are also studying the barriers and facilitators for a successful rehabilitation. So let's take a case study. In this, let's say we have a 55-year-old male who comes to the clinic and reports of tinnitus being their primary complaint. But he also reports having some kind of hearing problems and noticing, balance problems occasionally. Let's say you take a history and you notice that the person has some noise exposure history during the early days of working, and also may experience some kind of dizziness occasionally. And following the clinical investigation, let's say that you found and you diagnosed that this person has both noise-induced hearing loss as well as Meniere's disease. But the key thing here is that this person has come to see you because of tinnitus, not because of hearing problem or balance problem. That doesn't mean you don't treat them. Of course, you still need to look at the hearing problem and balance problem and see if they would need management. But because tinnitus is the primary complaint, I'm going to just focus on that for the purpose of this talk. And to gather more data, let's say you ask this person to describe what kinds of problem they have because of tinnitus, and also how their life may have changed as a result of tinnitus. And you can ask this question either through an interview, or a better way to do this would be to kind of send this kind of questionnaire before they come to your clinic, so that they had time to think and they time to write it down. If you cannot do that, then other thing that is becoming common is when they come to your clinic, you could kind of ask the receptionist to administer this questionnaire before they see you. So let's say that the response from this person for this question was something like this: my tinnitus can vary quite a lot. Although manageable most of the time, it does feel irritating and painful sometimes. I can no longer enjoy peace and quiet, which I have always enjoyed previously. I do not do the quiet activities that I've always loved. I avoid loud social events. I find aircraft travel aggravates my tinnitus. I avoid alcohol, caffeine, and certain types of food, as they seem to make my tinnitus worse. Using the computer often aggravates my tinnitus. Any quiet situation makes me feel pressure. This is something I have to cope with every minute of every day, day and night, no matter where I am or what I'm doing. Okay, so if you look at this report from this person who is complaining of tinnitus as a main complaint, and if you map this into the ICF framework, you will note that you can kind of see elements of body function, activity limitation, environmental factors, as well as personal factors. So there are body function issues, things like emotional function being affected, somewhat a sensation of pain occasionally, activity limitation issues like complaining of not being able to use certain types of, or not able to enjoy air transportation, and also tinnitus affecting the community, recreational, leisure, as well as socialization elements. And more interestingly, or more importantly for us, the person also gives some information about how certain things, like for example, food or being in quiet situation can kind of exacerbate tinnitus. In addition to that, person also gives some information about the coping style. So the person does tell that he has to cope, but he's not telling how exactly he kind of copes with this condition. So there's a little bit of element of coping style. So what you would note typically if they're not bothered by tinnitus is that there will be less activity limitation and less participation restriction. Whereas in this person, clearly it seems like tinnitus is affecting the life quite a bit, and there is a clear need for rehabilitation. So when we plan a rehabilitation, again we can apply this ICF framework. The first question we could ask is what impairment is most affecting their functioning. So that is something that we should ask, and then what kind of activities that is most important to the individual, but they're not able to carry out. Okay, so there's a second question about activities and participation, and then the third, even more important element is how their environment and personal factors either facilitate or hinder this particular situation. Okay, so if you combine your clinical investigation as well as this detailed questionnaire report, then you would find that in terms of functioning, there is some hearing problem that may have happened due to NIHL or maybe also due to the Meniere's disease, occasional balance problems. But more importantly, the person has come to see you because they have some issues in terms of emotional functioning as well as some sound tolerance issues. And then you have not being able to participate in certain activities, like not being able to attend some social activities, recreational activities, and also does not enjoy certain types of transportation. And then finally, the person also gave some information about how certain things could make it worse or better. So, looking at this, we could develop a plan for management. I think the ultimate goal for this person would be to develop a plan that helps him live well with tinnitus without much of a participation restrictions in terms of social, community, and recreational activities. So that's a long-term goal, but an immediate goal may be, while you have this brief description that they really did not give you much information about the environment and also more importantly about the personal factors, like what kind of coping strategies they used. So you may want to ask this person to keep a diary for the next 2 to 3 weeks on exactly noting down what they do, like how different situations may affect them and what they do. And I think it'll also be nice to maybe start some kind of sound therapy because they have hearing loss as well as tinnitus. Maybe a hearing aid would be a good solution. But if hearing is not a major problem, then even starting off with some sound therapy solutions would be a very good idea. And then because we know that diet can influence Meniere's disease, and also in this person, this person has clearly reported that diet can influence the tinnitus. So it would be nice for this person to examine, maybe make an appointment with a physician or a dietitian to explore what kind of dietary options can help reduce tinnitus or help not exacerbate the Meniere's disease. And finally, but most importantly, I think there is a clear need for psychological intervention. For example, CBT. So very few audiologists are trained to do this, but some psychologists seem to offer CBT for tinnitus. I think the idea here is that you develop a comprehensive plan so that the first step of the plan is to get more details and understand and put together an audiological rehabilitation plan, maybe associated with some sound therapy and some informational counseling. But some patients like him may also need other types of management plans. So I think to close this up, what I meant to say here is that thinking about ICF, I said that you could apply that using a classification, basically coding everything that you study, which is good for research work, but not for clinical scenario. But all of you, as a clinician, could think about any health condition or a disability using the ICF framework or ICF model. That means you gather information on the body structure and function, you gather detailed information about activities and participation, and then more importantly, you also collect data on how the environment and personal factors can influence these experiences. So those kinds of information is likely to help you develop a much more person-centered rehabilitation plan. So to close this off, I would say that ICF has many advantages over other disability models, including medical model or a social model. Because of the heterogeneity associated with conditions like tinnitus and hyperacusis, I think ICF is a really nice model to be used in this population. And ICF can be used for both research as well as clinical purposes. I think eventually, when there is more work on using ICF, there could be an ICF-based tool. Right now, if we look at any tinnitus measurements, I think much of the emphasis seems to have been placed on body functioning and a little bit of activities and participation. But maybe we could add some elements on environmental and personal factors as well. I think that could be a very useful tool. I am adding a few key reading, 2 papers on ICF related to tinnitus and 2 general papers on ICF model or a framework if you're interested in reading. So you're welcome to go back and look at these papers. And just before I conclude my talk, I just wanted to tell you that when we kind of think about tinnitus management, usually these 3 domains are important, focusing on auditory domain, attentional domain, and emotional domain. Audiologists are pretty good in managing the first one, but may not be so much in terms of attention and emotional domain. So in the last few years, our main research has focused on developing, clinician-led, usually an audiologist-led, internet-based CBT for tinnitus. So we are doing a series of studies. We have done a couple of randomized control trials in the UK. We just finished 2 randomized control trials in the US. So you're welcome to go back and have a look at this program, which kind of basically focuses on the other elements, attention and also emotional element. And quite often we also have audiologists asking for our intervention materials. What kind of intervention you used when you did these trials. So we recently came up with this book, which was just published a few weeks ago, which goes through the program, which kind of provides the complete CBT program that we have. It is written in such a way that it can be used more like a clinical manual. Those who are not familiar with CBT, they could just follow the steps. Or in other way, patients could also use this more like a self-help book, just reading through this CBT strategies. The nice thing is that these materials have been tested for nearly 30 years in numerous clinical trials across the globe, in Sweden, Australia, Germany, UK, and the US. And also, more recently, we took most of these materials and we rewrote. We rewrote the material so that it is written in a very simple English, so that even those without any background should be able to understand these things. In addition to that, we also added quite a few videos that people could watch in the companion website. So just thought I'll mention if that is of interest to you. So with that note, I thank you all for attending this talk, and it seems like we do have about 13 minutes for questions. So I'm open to any questions you may have.
Thank you, Dr. Vinay, for the wonderful lecture. And now the session is open for questions. I'll paste the link for the post test. You can go through it. And if there are any questions, you can type in the chat box. Thank you. Are there any questions?
Okay, I see. Saying, can ICF be applied in a daily clinical basis? So I think the answer is clearly yes. While I did talk quite a lot about how ICF can be used as a classification, is to code different elements. You can think about ICF also as a model or a framework. That means when you gather clinical information, you can gather information about all of these key elements, which is body function and structure, activity limitations. In addition to that, more importantly, gathering information about environmental factors and personal factors. I think the idea behind ICF is that instead of just focusing on the body structure or a function, which is more like a biomedical model, or alternatively just focusing on the society, I think the idea here is that you focus on all of these three elements, biopsychosocial elements. So I think in some way you can see ICF framework or a model is more applicable for clinical practice than research itself. Okay, I hope that answers your question. You can ask a more specific question if that is too broad.
I guess there are no more questions. So thank you, Dr. Vinay, for your time and delivering this wonderful lecture. I think it's a completely new area for most of us who haven't worked in ICF. So thank you so much.
It was my pleasure.
So this would come to we have come to the end of the webinar, that is the international webinar on assessment and management of tinnitus and hyperacusis. So before we conclude, we request some of the participants who have attended the webinar to kindly give your feedback about the webinar, so that we can still further improve, and how was the webinar, and what were your general feedback related to the webinar. You are welcome to provide it. You can unmute yourself and you can say it.
Hello, am I audible?
Yes, you are audible.
Okay. So I'm Rohit from KMC Mangalore. So it was very good and nicely organized workshop with eminent speakers who has done lots of work in the area of tinnitus in terms of clinical as well as research aspect. So thank you for arranging such a wonderful webinar. I'm sure whoever has attended has lots of information which they can use in their clinical as well as research practice. Thank you.
Thank you, Dr. Rohit, for your feedback. Anybody else would like to give feedback?
Hello.
Yes, ma'am.
Yes, good evening to everybody. My name is Kudsiya Khan, and I am currently working as an audiologist and speech therapist in Sion Hospital, Mumbai. And I've completed my bachelor's from TN Medical College, Sion Hospital, Mumbai, and my master's in audiology from Bharati Vidyapeeth University, Pune. This entire webinar series over the span of 2 days was extremely well organized, and there was not even 1 second of the entire webinar series where I lost attention or track of what was being spoken about. It was very enlightening, and it really threw light on a lot of new aspects of hyperacusis and misophonia and tinnitus that I think somewhere or the other down the line we missed out on knowing. So kudos to all of you, all the team, and thank you to all the resource persons as well as to the organizing team for having put together such a beautiful webinar series. Thank you.
Thank you, Kudsiya.
Good evening, sir. Sir, can you hear me?
Yes, you are audible.
This is Raj Suman. Good evening to all of you. Sir, the presentations were very crisp and clear, and we were looking forward for some more webinars like this, sir. Thank you for organizing like this.
Thank you so much, Rajasuman.
Hello, good evening, sir. My name is Kripa, and I am a student of JSS Institute. I'm doing my second year on Masters of Audiology, and as all those who spoke before me had said, these 2 days were quite enlightening, and not even for a second did I lose my attention at all. The webinar addressed topics which we normally do not address or see on a daily basis. So thank you, sir, very much for organizing such a wonderful webinar, and looking forward to such webinars in the future.
Thank you so much for your words, Kripa.
And just to mention, yesterday, we had some, time-related problems because the session started late, and some sessions extended, some time limit. So the questions we have noted down all your requests. Some questions could not be answered. So all the answers will be sent to everybody's email. We have all the email IDs. So all the participants' email along with the answers, it will be sent.
And we have requested permission to upload these videos in the official YouTube channel of AIISH. So, all the resource persons were kind enough to agree to upload the sessions in YouTube, because there was an overwhelming response, and because the 500 registrations got filled within 3 to 4 hours, so many missed the opportunity